Good morning. Good morning, everyone. Welcome to Zufall Health's Beyond the Smile, Wellness Prevention and Equity Symposium, where my name is Fran Palm. I'm President and CEO of Zufall Health, and we are so pleased to present this symposium. This morning, we are excited to have approximately 350 participants. And of course, that doesn't include the groups, the people who are joining in groups. So we expect it to be well beyond that. We thank you for your participation, and we are interested in hearing everyone's thoughts. Zufall Health has been in existence for going on 35 years and has been forever committed from the very first days of Dr. Zufall and his wife, who were committed to helping members of their community access affordable and quality healthcare. And we have never wavered from that commitment. And I'm sure all of you who are on this symposium today have the same commitment. So we are bringing you today quality speakers from various organizations, various experiences, plus our own Zufall experts who have their own expertise and experience to share. But all of you have experience to share, and we are here to learn from one another. And this is where good things happen, when we have a sharing of the meeting of the minds, people with like minds and people who have different ideas that will challenge us to think of things in new ways. So we are excited to hear everyone, and we are excited to have you. And I am so pleased and want to congratulate our team for putting this together. They have worked diligently to bring you a quality day of education, and I congratulate them for their efforts. Dr. Duncan leading the effort as our SVP of Dental Services, but I'm turning it over now to Dr. Rena Ramirez, our Chief Medical Officer from Zufall Health.
Thank you, Fran, and good morning, everyone. My name is Rena Ramirez, like Fran said, and I'm the Chief Medical Officer at Zufall Health Center. I've been here for only 18 years as opposed to 35 years that Zufall's been around, but I've seen it grow and progress into a tremendously wonderful health center. And I'm so proud of my staff, of our patients, of everybody who works every day to make this wonderful place work. I love the Beyond the Smile Wellness Prevention and Equity concept that Dr. Duncan came up with, especially around the integration of primary care and dental and medical and all the other wonderful things that we do, because we do this and we've done this organically since I started working here. I was thinking about the process, and when we first started thinking about going into using an EMR in 2009, we were looking for an EMR that had dental and medical together, and there were none. There were really none. So at that time, we decided we would pick the EMR that best suited medical and dental, and our dental staff were wonderful, and they adjusted and used the medical EMR in order for us to be integrated, so that we would have our patient demographics, our visits, our appointments, our allergies and medications all in one. So this was an intentional journey from the beginning to become integrated and coordinated, so we together could provide coordinated, seamless patient care that would be patient-centered, with a team embracing that patient and improving it through our development, our processes as we've gone across the years, including trauma-informed care approaches and other things. Right now, in addition to just adding dental, medical, and behavioral health integration, we have HIV integration, we have substance use disorder integration, we have all of the enabling services that work together with us. We just recently added a robust legal services. So we really try to bring the services to our patients and our communities in the best way possible, again, in a coordinated, concerted effort. This wouldn't be possible without our patients, our staff, obviously our payers, and our partners, HRSA, our HIV/AIDS Bureau, the Department of Health, the New Jersey Department of Health that really supported this effort since the beginning, NAC, the CDC, Delta Dental, the ADA, all of these partners contributed to our success and continue to contribute to our success. And as Fran said, we are very happy and proud to have experts from those partners and others outside that know so much, but also to bring you some of our internal expertise so that we can share what we know. And again, like Fran said, we can learn from others. So I'm very, very proud. I thank you for joining, and I am now going to send it over to Dr. Duncan.
Thank you so much, Dr. Ramirez. Thank you so much, Fran. Guys, I am so excited. What you guys are going to experience today is going to be a day full of learning, a day full of feeling me too and connections to what's happening. We're going to be spending a lot of time checking in on ourselves as healthcare professionals and learning what other people in our same profession across different specialties and across different ways of presenting or ways of practicing, how are they making sure that they're okay in everything that they do, and the ways in which they have been innovative and showing different ways to provide the care, and I think that's something that's going to be very, very enlightening today for all of us. And I am so excited. When you have a chance during the breaks, make sure you jump into the expo halls to check out some of our partners and sponsors and exhibitors to see what they have going on in there. But definitely take your time, get your coffee, put on something comfy. If you're at home, if you're at work, just make sure that you have a nice quiet space, because there's going to be a lot of learning here today. So I do not want to take up too much more of your time before we get started. I just wanted to run down a little bit of what we're going to be expecting today. This morning, we are going to have a plenary session. We're going to have a keynote speaker who I'll be introducing in a couple of minutes. We're going to have some of our great partners in public health from the DOH and NAC, etc., that are going to share a little bit about what they've been doing in this field and how they've been contributing to integrated care. And then we're going to have a bunch of sessions today that really highlight some of the great things that take us beyond the smile. And beyond the smile isn't just about, dentistry, because we want to show that dentistry is primary care, and every aspect of healthcare, whether it is medical, behavioral health, public health, all of it together is a part of the package that we present at Zufall. And we don't see any separation, because our patient is one human being and we take care of all of them. So that's something that's so exciting. So I am going to do an introduction of our program with some housekeeping items. So all attendees are muted and encouraged to use the Q&A box to ask questions. You can raise your hand at any time or use the chat for technical assistance. We offer dental, medical, nursing, public health, and CHES and MCHES continuing education credits. To receive credit, you must complete a survey. The survey link will be posted in the chat at the end of the session. Dental, medical, and nursing credits are offered at the session level and require a survey submission for each session. Public health and CHES, MCHES credits are offered only for the full day symposium and require one survey submission. Today, our keynote speaker is Marcqwon Daywalker, MD. Dr. Daywalker is an integrated family medicine physician and Executive Vice President of Clinical Services and Chief Medical Officer at Avenue 360 Health and Wellness. Previously, he served as Chief Health Equity and Wellness Officer at Access Health Community Health Centers. Daywalker is a faculty member and health center coach for the National Network of Oral Health Access, NOAA, Integrating Diabetes and Oral Health Collaborative, as well as an adjunct faculty for NOAA's Culturally Appropriate Care Learning Collaborative. He is also co-chair of the Justice, Equity, Diversity, and Inclusion Committee with the Association of Clinicians for the Underserved. In addition, Daywalker serves on other state and national committees to improve healthcare services and has been a speaker at state, national, and international conferences. He received his medical degree from Morehouse School of Medicine. At the conclusion of this program, participants will be able to educate major stakeholders involved in the operations and delivery of providing care to dental patients regarding the intersection of trauma and dentistry, internalize the human connection between the audience's dental experiences to that of their dental patients, provide trauma-informed tools for providers and insight to how leadership as well as organizational operations teams can provide support in the delivery of trauma-informed dentistry. I am so excited to introduce you all to Dr. Daywalker. Dr. Daywalker?
Yes, thank you, Dr. Duncan. All right, so we'll go ahead and get started here. Really a pleasure to be with you guys this morning. So my talk would be over trauma and dentistry, and I entitled it, Who's Going to Tell Them? So just to give you a little bit of background about myself, I'm sure Dr. Duncan has done a fabulous job already, but currently EVP of Clinical Services. So I have that administrative hat for all the administrators that may be on our call this morning. And also serve as the Chief Medical Officer. So I also have that clinical piece. And I additionally want to share, especially in this space, when we talk about dentistry, I'm actually over our dental program as well. So yeah, you guys are near and dear to my heart. So let's go ahead and get started. Next slide. So I really wanted to start here and just share, I guess, my secret here that has in large part unlocked my success early in my career, and that is trauma-informed care, which really led me to the ideal of this concept of like human-centered care, which I'll kind of dig into a little bit more in the coming slides. But I really wanted to start with our primary care association here in Texas. Ours is the Texas Association of Community Health Centers, which of course provides us all the technical and training assistance and all of that good stuff. Additionally, kind of what they brought in a few years ago were these piloted transformations around trauma-informed care. And I'll tell you personally how it transformed my care patients, strengthened my connection with patients, advanced personal well-being, as well as introduced me to this human-centered approach. Next slide. So this approach really helped me delineate between the technical skills that we learn in dentistry or clinical skills, truly separate and apart from my art in the delivery of medicine. Me specifically, I had a mastery of primary care, which again is separated from being truly connected to my patients in ways that could maybe not leave as lasting as the impact as I wanted to, but the idea of the human-centered care approach really started to resonate with me very early on in my career. And part of this human-centered care approach is understanding and appreciating the distance, just inherently having the knowledge, the privilege in terms of caring for the human body. Also, too, just being mindful of this power differential, understanding that as humans, we all have implicit biases, understand the importance of meeting people where they're at. Also, in light of that, you also want to just be aware of different historical, cultural, and gender factors that may drive behaviors. And also, too, once you kind of become more informed with these differences, you want to celebrate them, not just acknowledge. You want to celebrate. And lastly, when we're doing this thing that's such a sacred practice between two individuals, someone being very vulnerable with you to share their medical history or allow you to perform these operations, you want to honor their personal choices, right? Being able to say, if it's not the time to do a procedure, it's not the time to do a procedure, or is not the best approach to doing something for that patient, just kind of honoring that and believing in that spectrum of care, that lifelong continuity of care principle that we have with our patients. Next slide. So for our purposes today, I wanted to just really kind of focus on this ideal of something being actually real and happening or imagined. And I just wanted to land here as we kind of talk about this thing throughout this presentation, is that it really doesn't matter. It doesn't matter if the fear is legitimate and or not. It has genuine consequence. I put this slide in here just to kind of illustrate that a little bit, because for all the experiences and circumstances that we go through, everybody kind of responds a little differently, right? But here's some causes of dental trauma just to kind of think about. So from the patient perspective, you may have a true physical tooth trauma, right? Meaning that it actually impacted the tooth, or you have some issues in the oral cavity, which is real. But also too, the same breath, there could just be thoughts, beliefs, or generalized customs that they may have around like oral care, dentistry, and things like that, that has true physiological and psychological circumstances as well. Outside of the patient, personally, it could be something around family, right? The way the family kind of views healthcare, dentistry, what it means to go and see a dentist. That storytelling has a huge impact. Also to relating to access to care and also to the delivery of care. In addition to that, there's several like societal portrays, right? You'll see things on TV and movies, social media, that also kind of feeds the narrative when we talk about delivery of healthcare and dentistry. Also too, as you kind of overcome those pieces and you say, you know what, I do need to go see a dentist. I do need to go do my regular kind of prevention and things like that. Just the navigation of the health system sometimes can be difficult, right? Which can lead to some frustration around that piece of it. And this last piece here, I put the delivery of dentistry, and I have question marks because I do want to see a little bit of engagement. I'm wondering, before I get started, is there anybody currently on our call here that has any thoughts, ideas around how we might have some real or imagined issues around relating to trauma in the delivery of dentistry? And I can't exactly see the chat, so I wonder if Dr. Duncan can help me a little bit. I just want to see any ideas we have before we get started.
Okay, I'm looking in the chat. When I see something, I'll let you know.
Okay. If nothing just yet, I'll go ahead and move. I won't wait too many times here, but I would love to hear what you guys think as we kind of move through this thing. All right. So with this next slide, I really wanted us to kind of anchor in around the facts as it relates to physical trauma in dentistry. So in the US, 1 in 4 people between the ages of 16 and 50 have experienced at least a traumatic dental injury. Nearly 80% of dental injuries occur before the age of 20. Untreated dental trauma can affect a child's behavior, social isolation, as well as oral health quality of life. And adolescents with broken teeth are 20 more times to be disruptive in their daily lives than those without. And here are just some, okay, what you got?
Sorry, we have three comments. The first one says, possibly not having the time or resources to accommodate a patient's trauma. The second one says, general anxiety disorders can present a host of issues and cascading experiences of trauma when in the dental chair. We have trauma can include sports-related injuries. And another comment is bringing on panic issues.
I love that. And you know what? I'll expound on each one of those as we go through this. All right. Next slide. Let's go to the psychological trauma. Perfect. Okay, just some facts around psychological trauma. In the US, about 36% of people have fear of dental treatment and 12% with extreme fear. A meta-analysis, which is like our gold standard of research studies, a meta-analysis of 31 studies found that 15% of people worldwide have dental anxiety. So anxiety specified around dentistry. And I know 15% may seem small as a number in this context, but we're talking about worldwide. We're talking about billions with the B, right? And those causes are fear of dental experience, a previous negative experience, cost of treatment, gag reflex, and a fear of bad news. Next slide. So with those staggering statistics, how do we begin to address the real physical trauma as well as the shadow system underneath it that relates to psychological trauma? And the answer is that it starts with ourselves. So as we think about delivering the best care possible for our patients, we always want to think about, at the end of the day, with all the knowledge, training, experience that we've received, we also have to connect, right? So it begins with self-awareness, just kind of being aware of where you stand today. And we'll talk about how we can kind of get to our past experiences. But you want to also think about your communal historical perspective, right? And what I mean by that is the community that you grew up in and the way dentistry was viewed. Was it a privilege? Was it something that was just routine? We just did it. Was it something that you learned very young to brush 3 times a day and floss twice a day, or whatever the case may be? And with the ideal and perspective that may not be somebody else's truth, right? Your cultural beliefs, right? Is it really even that important about oral health, just in general? Your own personal truths as you begin to kind of grow up and explore and think about your own ideas around certain things as it relates to health. And again, you want to consider your past experiences. Next slide. So how might we do this? What does this even mean? So here's a picture of a much younger and cuter version of me. But it's really important for us to figure out how we felt when we were young. So my nickname growing up was Marcqwon. And just in general, I'll be honest with you guys, I had a fear of dentists. I was actually scared of hospitals. Still don't like hospitals very much today, oddly enough for me to be a physician. But I used to brush once a day. I was actually never taught to floss. Lacked dental prevention, had crowded teeth at both the top and lower parts of my oral cavity. As you can see here, this was my standard smile. I would grimace the smile to hide my teeth. So I actually avoided taking pictures. And this is my reality. This is kind of how I grew up. This is how I was raised. This is how I viewed the system that was supposed to be taking care of me, right? So that's part of that deep reflection to kind of look at. And I kind of chuckle now looking at these pictures because it's so far removed from where I am today. So let's go to the next slide. So as Marcqwon grew up and eventually became Dr. Daywalker, I was able to overcome this dental fear. And parts of that was leveraging some of my protective factors. I had my stepfather who, when my mom married him, we started to get access to dental insurance. And lo and behold, these fears of medicine and dentistry led me to eventually become a physician as well as a dental faculty member within the National Network of Oral Health Access. But this kind of just shows my dental story. As when I got to college, I finally kind of embraced the idea of getting braces. I got those feelings that I needed in medical school from not having great dental care kind of growing up. Actually had to have some extractions, but now today get regular cleanings, prevention, floss, and brush regularly. And I even have these guards recommended by my dentist saying hey, I think you bite down or clamp down during sleep or when you exercise. And so just kind of goes to show you that this is the power in turn that we can channel and actually share with our patients. So as you think about your own journey and story, from your childhood kind of beliefs and how you thought about dentistry to your crosswalk as you became an adolescent, then your crosswalk as you became this professional would allow you to kind of connect with patients. And I'm gonna show you how we can do that. Next slide. So how do we do this, Doc? We need to start developing our own story. It's really important for us to kind of consider our beliefs, but also at the same time juxtapose that with reality, right? Everybody lives with a little bit of cognitive dissonance, right? That's why people will always say, hey, there's 3 sides to every story. It's your side, their side, and the truth. So you want to consider your beliefs and also as best you can figure out what actually is happening, your reality of the situation. But also too, you want to understand that, we're not robots. So you want to make sure that we're aware of the emotional state that we are in or were in as we reflect on our past experiences. And as best we can, we want to be as vulnerable as you feel comfortable with You want to be vulnerable with yourself, number one, but as best you are comfortable with sharing with someone else. And in that same vulnerability, that allows for that connection, for that educational piece to really seek in. And we'll talk a little bit more about that moving forward with your patients. You also want to be sure to kind of discuss your supports, right? I think all of us, we have protective factors that we can kind of highlight that would allow other people to think about all of the resources that they also have in their journey within like dentistry. It's also important to acknowledge your own personal resilience, right? Telling that story of how you overcame something and kind of where that leads you to now. And always to reflect on whatever your sense of accomplishment may be. For me personally, kind of sharing with you guys, coming from this ideal of I was afraid of dentists, didn't like hospitals, but now today, like I'm a professional that kind of work with dentists, and also from time to time I'm in and out of a hospital doing work. So you want to make sure that we capitalize on that too. And part of this is within that psychological capital model of like PERMA, which I didn't have a whole lot of time to put that part in. But that's an evidence-based tool to kind of strengthen like resiliency and empathy. Next slide. So after the development of the story, this will kind of bring us back to this skill of trauma-informed care. So what exactly is trauma-informed care? Trauma is best defined by the 3 E's. The 3 E's being either one catastrophic or big event, or several small events that lead into someone experiencing a state of trauma that has long-lasting effects. So what that essentially means is that it's not just those really big things that may happen, whether it be like a weather event where you survive like a hurricane or earthquake or whatever the case may be, maybe a major car accident, but also too, we have these like micro traumas, right? These micro traumas could be anything related to like maybe the social determinants of health. Oftentimes our patients don't have access to a lot of things. So on a daily basis, if you were to think about, I'm worried about where my next meal is coming from. I'm worried about, my transportation back and forth to work. Those things have the ability to combine in such a way that it does have the same exact impact of some large organizing kind of trauma. So that's kind of like the general definition of trauma. And the next slide, we'll kind of dig into a little bit more. So the reasons why trauma-informed care is so successful is that it kind of taps into these pillars being not only physical safety, but also psychological safety, trust, choice, collaboration, empowerment, peer support, and also, again, recognizing those historical, cultural, and gender factors. And once you've incorporated these 4 R's, you'll begin to really transform your practice. The 4 R's being that, first and foremost, we have to realize that both physical as well as psychological trauma is a real thing and it does exist. You want to recognize what those signs and symptoms are of trauma. And you would like to respond once you do recognize those signs and symptoms of trauma. And it's not the idea that you have to necessarily know anything related to trauma-specific therapy, but if you can at least respond in a trauma-informed way, and we'll talk about that as well, we can actually appropriately mitigate some of these effects. And probably most importantly, and once you're kind of more trauma aligned or trauma informed, you can actually avoid re-traumatization. Okay. Next slide. So as it relates to our patients, this is very important, especially for the communities that we serve. Oftentimes, community health centers, the patients that we take care of are underserved populations. And with that, most times our patients are the ones that have been largely like marginalized in society. They are very complex cases, whether they have multiple comorbidities, uncontrolled medical conditions, issues around social determinants, maybe income is an issue. So dentistry in large part is considered a privilege. So for these types of patients, not only are they experiencing significant negative factors that may drive trauma, they also have a lower set point in terms of being able to be resilient, right? Because they chronically live in a state of sometimes the survival mode where a lot of oftentimes we don't experience this, so we have very little insight to that. Also, too, for populations like this, once you have lived in a state of like chronic trauma, if you will, there is like a general mistrust that reshapes a worldview. Also, this ideal of not feeling very safe. So when a patient does come see us, sometimes they've already overcome a lot of barriers, right? Number one, it may be some health system mistrust, but they had enough pain for them to even come in, right? Also, too, sometimes patients feel like, especially from this population, may not already be seen, and especially in the dental space where it's, it's kind of procedural sometimes. It can feel sometimes dehumanizing, but also, too, just by sheer barriers that they have in terms of accessing healthcare or even being able to keep over recommendations following the procedure, there's this preconceived notion of maybe non-compliance. Next slide. So with all the challenges that we have as providers, clinicians, dentists, dental hygienists, you name it, even administrators, as we think about how do we do the best job of taking care of these patients, given the context that we have, we mustn't forget about ourselves and our own trauma stewardship. Because there are different types of trauma that we must be aware of. As we kind of think about it today, thus far, what we talked about is primary trauma. Primary trauma is the trauma that has directly affected you because you've witnessed or seen some type of event. Secondary is meaning that when witness here means that, like, let's say maybe we're watching TV, right? And we saw that something happened to a group of people, right? Or we heard it on the radio, right? And that has a way of also affecting us, especially if we identify with the community being affected. And then there's also vicarious trauma, right? And this relates to the care of the parties directly involved in something that you feel empathetic to, right? So as we've learned about the power of like transference and countertransference that can happen between patient and provider, so can trauma be passed in this exact same way. Next slide. So this brings me to a much hotly kind of discussed topic of like clinical burnout, which all providers, clinicians, dentists, dental hygienists, even administrators for that fact, need to be thinking about actually daily. And something I would like to highlight is that clinical burnout is not an all or nothing thing. It is a spectrum, right? Really the four main symptoms of clinical or a burnout just in general is depersonalization, emotional exhaustion, a lack in sense of personal achievement or cynicism. Now, what I would like to highlight here, just inherent for us to do our jobs, occasionally we have to tap into some of these things, which is already a slippery slope, right? So when we think about depersonalization, it would be very hard for us to do our jobs if we did not have enough separation between the ideal of we have to cause a little bit of pain to do this, right? To actually get the better overall outcome. Pulling the tooth is not a, painless procedure. I know we put someone to sleep and, we'll numb it up or something like that, but after they're in the pain, right? So we got to think about being able to do this job. We're not trying to cause pain, so we got to separate that a little bit, right? When it comes to emotional exhaustion, just dealing with some patients that may already come in and say, hey, doc, or this tooth made me come in. I really don't like to see the doctor, right? Or again, that pain from a procedure that you got to do, that stuff can lead to emotional exhaustion from you, right? Having to be like, well, I'm here to help you, not hurt you, right? So that can have some feedback into leading to some emotional exhaustion and maybe having to mask a little bit of that cognitive dissonance that you have to deal with to do the job. Also, too, the objective outcome, again, from a procedure, you may feel like you've done a job well done. I actually did a really great job with that filling, or that was a really clean extraction. But it's not necessarily that the patient feels that way. They're just like, oh my God, I'm happy this thing is over. And I'm just still in so much pain, doc, right? But you're like, I did such a good job. You're going to be having such a better outcome. and having that not necessarily direct kind of personal achievement that you probably would like to see or hear from the people that you take care of. And then lastly, like cynicism, that mismatch, right? We see ourselves with this cape. A lot of us have come into this space to, first and foremost, because we have a heart to service. So, you know, we sacrifice or we give up a lot of our time to be the best professionals we can be. And when that's not necessarily being received in the exact same way, that can lead to a little bit of cynicism. So in terms of like clinical burnout, and as much as burnout is a organizational wide phenomenon, like organizations and the workplaces and the things that we do within the context of work leads to burnout, there's also some things that we have to consider in the delivery of our care. Next slide. So how does this really fit into our discussion today? It fits in because of connection. This actually gives us the greatest opportunity to address burnout, at least on the individual level. Again, burnout is an organizational phenomenon, it's workplace issues. There's really no amount of yoga. There's no amount of running, meditation, sleep, eating better that would necessarily overcome burnout. But again, what we can do within the confines of how we work is the connection piece. So connection, in terms of the intentional like rapport building with you and your patient, this enables that fertile ground to have trust, which inherently leads to psychological safety. Something that I think just in medicine in general, the behavioral health folks got to figure it out. Some of the psychiatrists got to figure it out. But in medicine, dentistry, the rest of us, we haven't leveraged this enough. But there has been vast studies showing that there's a true therapeutic patient-provider relationship if you tap into it the right way, meaning that on average, you just get better outcomes because a person's physiological state may change with the fact that they're actually hearing your voice or in your presence. And on top of that, if they actually follow your recommendation, histochemically, their body would produce different antibodies, different hormones that lead to better outcomes, right? Let alone someone just being happy and genuine to see you. So multiple studies have shown reciprocity of this relationship, which can be healing for both the patient as well as the provider. Next slide. So here's a concrete way to start building like this connectivity model. So just kind of going back and thinking of the different iterations of yourself and how you felt about dentistry at that time will help in the process of reflective medicine. This would allow you to move from that Dr. So-and-so to being Mark, so that you can connect with maybe that pediatric patient on that level, furthering that capacity for empathy. You want to intentionally acknowledge the fear that you once had so that you can tap into what is needed for that particular patient given the context. So overall, this improves learning, enhances clinical practice. It allows us to contextualize the human experience within that clinical dogma that we find ourselves into in the swings of care. This allows us for the integration of theory of what we do within our own practice, our own experience. It provides that critical reflection, making that space for empathy, and it gives you that different kind of cognitive flexibility as it relates to different perspectives. So it's a very iterative process, and just like any other iterative process, as you continue to do it, you start to build that muscle. Next slide. So that really feeds into this ideal around narrative medicine. So from a reciprocity standpoint, you want to really start to kind of engage your patient through the procedure of storytelling. And this is actually the most authentic way that someone can share with you how they feel and giving them space to do that. And that could be through art, literature. Allow your patient to be as creative as they want in terms of them telling you exactly why they came to see you, right? What this has shown is that it improves clinical care, strengthens their beliefs in treatment and recommendation, and it helps us better understand that patient's life, furthers that empathy, adds into or flows into that patient-provider relationship that we just talked about, as well as increasing provider well-being. So as you think about it, with the holidays coming up, Part of the reason why we love going to see our families is because of that connection through storytelling. You're going to hear all of these stories that people have had and shared, and that's the way we commune. So doing the same thing with your patient is very, very impactful. Next slide. All right, so here is a very concrete technique that can be leveraged to elicit stories in a psychologically safe way. So the BAVE technique, and I think we have those handouts for you guys as well. B standing for background, A standing for effect. T is for the most troubling, H is for handling, E is for empathy. So as we get that like history, kind of, like what brings you in today, following this simple kind of model allows you to kind of really kind of strengthen those positive attributes around somebody's like pain points that kind of shows a psychological safe way of doing it. So really simple article to kind of read through and immediately add this to your practice. Next slide. So with any great technique, you also want to have some skills associated to help you kind of support that. Trauma-informed like motivational interviewing, you want to make sure that you have like further follow-up questions to be able to kind of expertly address what's happening. And the goal of MI really and truly is to overcome ambivalence. So if there's maybe a treatment that or recommendation that you have with a patient, this is like a really great thing to use once you kind of have that trust built in that we were talking about. But those skills are being like open-ended questions, affirmations, reflections, and summaries. We also provided like a handout for that as well. Next slide. And in summary, here are our key kind of takeaways. Number one, we want you to be very authentic and vulnerable. Number two, just be aware. Again, going back to those 4 R's, you want to realize that dental fear is very real. Number three, we want you to be prepared. So you want to recognize anxiety and or fear when you see it. You should be able to respond now, at least with the bathe technique to kind of get you started. And we also just want you to be human and avoid re-traumatization. So doing that trauma-informed motivational interview and using those skills of MI that we share with you. And then lastly, we just want to kind of reclaim that humanity back in dentistry, which will, again, transform your patient practice, but also to reciprocity in that kind of fill you back up to kind of prevent burnout or mitigate burnout. Next slide. And here are my references and resources. I hope I got through that quick enough where I can answer some questions.
Dr. Daywalker, that was amazing. We had so much engagement in the chat while you were presenting. People are resonating with what you were saying. They saw themselves in the stories that you were sharing. We do have a few questions, but I want to make sure and get you some of the comments and so that you can know the level of engagement before we go to the questions. So when you were sharing the picture of Marcqwon, someone said, my oldest grandson was so like this. We tiptoed through his inability to eat without his fingers moving around his mouth. He just finished Invisalign, has a great job right out of certification training, and is engaged to a nurse. So they were sharing their the childhood trauma story, and one of our attendees mentioned when you were talking about your own trauma story, and she said, as you said, many people have experienced traumatic dental injuries. I myself experienced dental trauma very young, which has caused great anxiety as an adult when attending dental appointments. Another put a comment saying that the bias she experienced from staff at the dental office traumatized her. We had another one that said, previous trauma as a child with painful dental procedures or feeling embarrassed with current adult teeth due to avoidance of dental visits is what keeps her away from the dentist. It could make people postpone their dental care, not wanting to smile, leads to other factors. And someone said something very interesting. I believe a significant part of the fear and trauma many people associate with the dentist comes from the way parents used to threaten their children, saying things like, if you don't behave, they'll take out all your teeth, or if you don't stop acting up, I'll take you to the dentist.
Absolutely.
Very interesting.
Absolutely. Yeah.
Very interesting. Another one says, I also didn't go to the dentist for 10 years, ever since a traumatic dental experience when I was 14. So people are just sharing their own experiences, really just to say that they are getting it's sort of like seeing themselves in everything
Yes.
that you're presenting, which is so powerful. So let me get to the questions so we can have enough time to really get to them. We have a couple of questions. I'm going to start with the first one. Ruby Leal asks, socioeconomic factors contribute to disparities in dental health. So what can be done to bridge this gap? But also, how can dental professionals or any other professional advocate for policies to improve oral health access for disadvantaged communities?
Oh, I love that. I love that. And let me not make assumptions. Is everyone here a part of a community health center or no?
I think there are groups of people from community health centers. We have people from dental schools. We
Okay,
have people from public health organizations.
gotcha.
Yeah.
All right. So the first part of that, we're talking about social determinants. So in the lens of social determinants, how do we do that? I think you have your structural barrier, right? The actual objective thing that may be keeping them from going, whether it be transportation, finances, not having access to a dentist, but the real like, I think I can touch, feel, right? See. And then you also have that stuff that you can't see, right? That fear, that anxiety, whatever that case may be. So taking this again, this trauma informed lens to it. First and foremost, you want to talk with whoever this individual may be, and figure out what their barriers are and their pain points are. Oftentimes, as professionals in this space, we are aware of things that can help people overcome barriers, right? Whether it be like transportation, you think about things like, okay, what about the local kind of public transit, right? Or as an organization, you may say, hey, you know what? I want to address transportation by having like Uber Health, right? So we're really good at doing those pieces, right? Community-based organizations, they exist to exactly take care of some of those things that a person may have issues around. So that right there would get you that piece of the objective touch point of actually allowing the thing to come. The secondary hurdle is going to be that coaching piece and meeting somebody where they're at. To be honest with you, something I wasn't able to put here just in terms of time constraints. There's something called the trans-theoretical model of change. And what the trans-theoretical model of change speaks to is that with anything that you discuss, everybody's on this continuum of doing something that they haven't done before. And that could be they're at the pre-contemplation state, the contemplation state, the preparation state, the action state, the sustainability state, or the relapse state, right? So you really have to think about where is that person at, right? Because you can have the resource available, right? You can have the funds available. And sometimes it may just be where they're at. So you have to think about where you can do your coaching and counseling at. So and the theory goes that you can't really move somebody more than one state at a time. So if someone's at contemplation state, you can't move them to action. You got to first get them for preparation, right? Okay. All right. So you figured out that they have an issue around transportation and you got transportation for them. Now the coaching and counseling is like, what does it look like? What time are you actually gonna, or what day you're actually gonna decide to go? What time are you gonna be there to make the transit? Who's gonna kind of keep you accountable? Can I give you a call? That's that coaching and that hand-holding piece of it too. So it's not about just having the resource available. It's about being able to move them from that next stage of change to the very next step.
This next question is referring to the presentation itself. Lawrence Birch is asking if you could explain the difference between secondary and vicarious trauma again.
Yeah. So secondary trauma, let's think about it in terms of the senses. Something that you can see, taste, hear, smell, that possibly you weren't directly involved in it, right? So I was happy to just watch while I'm watching TV, right? And I see that some rioting occurred somewhere that I don't like to see riots. And that could be like, oh my God, I can't believe that's happening, right? Versus the vicarious trauma, which can even be like historical. If you were to like read about something that happened to a community that you identify with, right? Let's say in my case, right? Let's say something like slavery, right? So if I were to like just, come across something and I identify with my people that have gone through something, right? Then I can feel that way. So vicarious trauma has this way of identifying in such a way that you are very empathic to the people that it's affecting, not just the act itself.
So much. We have a great question from Dr. Karen Kemp. As a practicing pedodontist, I would love to see all healthcare providers and essential stakeholders, such as insurances, state and federal health entities, etc., embrace more creative steps that allow for more informed parental engagement, compensation for oral health education for parents and caregivers once a year, incorporating social determinants on intake patient forms, and expanding on it on the CARES risk assessment tools, creating space to accommodate parental traumas and educational perspectives in daily care is not currently built into the practice of dentistry. Can you share thoughts on how advocacy at this level is changing?
My goodness, I love that. I love that. And when are you running for office? Because I need to vote for you. All right. So read the last part of that to me one more time about it, Duncan.
So the last part of it, I'll start from we get the part about the compensation for the right. So the last part is creating space to accommodate parental traumas and
Yes.
educational perspectives in daily care is not currently built into the practice of dentistry. Can you share thoughts on how advocacy at this level is changing?
Ooh, how advocacy at this level is changing. Here's what I'll say. This is a really good question. Um, I'm not sure if this is being leveraged in the dental space or not. Um, and maybe Dr. Nucky, you have this answer. Are there opportunities for like shared medical appointments or group visits in the dental space?
I think in some scenarios people have been working towards doing that.
Okay,
The troubleshooting of it being effective is still
gotcha.
on
Okay,
the table. There've been some barriers such as people just don't have the time to spend all day, which we think is convenient, but for them, they just want to get in and out. So it varies, but I think there's a work in practice for this, but specifically on the piece on addressing parental traumas. Oh my gosh, I love that. And I'm going to start brainstorming ways in which we can really make that happen.
yeah. So here's what I said. The reason why I was asking that is that that group dental or medical model is amazing. And part of the reason why it's so amazing is that it allows space for the education as well as receiving treatment, which kind of gives you that space and time. And again, that connectivity piece and the reason why providers feel so refreshed by doing it is part of that, right? You're not pressured to be to treat your level of care as like numbers, right? You get a chance to really connect. So that's one thing I was going to say. The other piece in terms of advocacy, there's a lot of different ways to go about advocacy. Advocacy could be you at an individual level, kind of going up to your like, your local, elected officials, um, that route, and kind of seeing what kind of health health things are being talked about, and you can actually really and truly put it on the agenda in terms of like your city council to have those things being discussed. They have their monthly meetings, and you can actually get on the agenda, right, and advocate in that way. You can advocate from a organizational perspective, right? Most organizations have some piece of advocacy associated with it, whether it be through them having a level of influence from a private level or from a public perspective. They're always doing advocacy. If you're part of a public entity, you also can do that on the national level. You have things like NOAA, right? All the things that we have within our community health center spaces. So there's a lot of different ways to kind of get involved in that advocacy piece of it. But I love, love, love the idea of like breaking the cycle, really, right? Passing down those traumas, right? When you have that parental piece that, have that own history, but haven't been educated against that. So they pass it down. It's a very real thing.
We have a couple more questions before we have about 3 more minutes. So 2 of the questions are similar, so I'll ask that question last, combine that to the last question. We have a question that just mentioned, the tight schedules that we have in offices. How can a provider with an overbooked schedule still implement these techniques and approaches you mentioned?
Yeah. So I love that question. First, you got to build the muscle, right? And once you build that muscle, you're going to become really adept at doing that. What I mean by building this muscle is that it's the same way our training worked, right? We did so many of these procedures, so many of these things, so many. By the time you graduated, you're like, I can do this in my sleep, right? So once you get started doing it, it's going to take you a little bit of time, right? Oh, what is that acronym again? Oh, what kind of question should I ask right now? But once you've kind of done it and done it and done it, you'll realize like reflexively, you're practicing MI skills all the time. When you do have the opportunity to engage, you're using some of that BAVE technique, and it starts to become very authentic versus being like, what's the next thing I'm supposed to say? What's the next thing I should do? So it goes back to like just getting started with some of these tools, and you don't have to go through the full breadth of everything each time, right? You do what fits in the applicable amount of time that you have.
Thank you. So the 2 that I'll combine is more like a comment. So I'll just mention the comment and then I'll ask you the last question because we have 1 more minute. The 2 comments we're talking about knowing the risk and the current trend that most likely coming soon they'll be removing water fluoridization on a city and town level. We as healthcare providers really need to come together to try to educate and not fuel the education and misconception. So that's the comment. And then the last question was the stigmatization or mislabeling as non-compliance and neglect. What can we do for that, and how can we avoid doing that as healthcare providers?
Yeah. So downstream, we could do something about it. Upstream will be kind of that education piece, that prevention piece, getting the bodies that do messaging, kind of fixing that piece of it. But downstream, what we can do as providers is to shift the language to more of a strength-based approach. So for an example, instead of saying someone is diabetic or I have diabetic patients, you can shift that language to a more strength-based formula, and saying something like a patient that experiences diabetes. And what that does is instead of identifying and taking the power away from someone and saying, hey, you're just this thing, it gives the power back to them to say that I actually have some control and autonomy around changing what I currently have a diagnosis for. In that way, it starts to shift perceived biases around certain things. So that's how we can do it downstream in terms of on our level.
Thank you so much, Dr. Daywalker. Really appreciate it. And now we're going to move on to our next speakers for this morning plenary. Our next speaker is Omolola Taiwo, PhD, MPA. Dr. Taiwo is the Executive Director of the Office of Primary Care and Rural Health at the New Jersey Department of Health. She currently leads the office in assessing statewide health needs, addressing rural health issues, and ensuring vulnerable communities have equitable access to skilled healthcare providers and healthcare services. Her previous focus areas have included health policy, analysis, HIV prevention and harm reduction, women's health, immigrant health, sexual violence prevention, and community health worker initiatives. She holds a doctorate in community and behavioral health from the University of Maryland, a master's degree in public health specializing in health policy and management from New York University, and a bachelor's degree in public health from Temple University. Good morning, Dr. Taiwo. You have the stage.
Good morning. Oh, thank you so much for that introduction. And there's actually a bit of a shift because I'm talking a little bit more about our performance management in this presentation. So I'm really excited to, engage in this conversation. So yes, as Dr. Duncan had mentioned, I'm going to be talking about how New Jersey is driving better health outcomes. Next slide. So essentially just kind of going over a little bit about the Department of Health, the public health infrastructure grant that our state was awarded a few years ago, and then what performance management and quality improvement, looks like and what we're hoping that it looks like going forward. All right, so just a little bit about the Department of Health. I mean, a lot of times when people talk about state departments of health, you have lots of ideas of what they do. Sometimes you're thinking about them on a local level. So your local, Department of Health is often looking at, quality of food and environmental factors, lead, testing. As a state on a whole, our goal is to improve the well-being and quality of life for New Jerseyans. And so we provide a wide array of essential services, and we implement them by, really utilizing measures that prioritize public health. So that's as a large, high-level idea of what the Department of Health does. So, specifically, what do we do? Disease prevention, health promotion, and education, emergency preparedness. So if, there are, COVID ended up being one of those emergency preparedness situations, licensing, regulation, health data collection analysis, and then health regulation policy and development. So that's a bit of what we handle as a state. So a few years ago, about 2 years ago, CDC, especially coming out of COVID, there was really an understanding that there really just wasn't enough resources in public health. We were faced with this massive pandemic that impacted every corner of the world. And it was really clear that we just have not been investing in our public health systems, both on a state and local level. And so CDC, it's gracious enough to award about $4.5 billion across the country, in order to ensure that departments of health, both on a state and local level, have the capacity to build up their infrastructure and their workforce. So New Jersey is one of the states that received that, grant. And really, we were looking to transform. We were looking to understand how to modernize and make sure that if there's another, whenever another issue arises or another health challenge arises, that we have the capacity, that our public health infrastructure has the capacity to handle that. And so that is what our goal is really to strengthen our public health practices, reduce health disparities, and then provide support to the most impacted communities. So some of the really key outcomes of this FIG grant, right? So we call it the FIG grant more often than not. And it's really to improve the workforce. We realized that across, as I said, local and state departments, we really didn't have an adequate public health workforce to do the work in a really robust way, right? In a way that understands primary, dental, mental health, in a way that understands primary and secondary and tertiary prevention. Just really across the bridge, we really didn't have the workforce that we needed. And then the foundational capacities, the processes in place, really just making sure that everybody had the understanding and the knowledge to move forward and with a public health focus. And then data modernization. The world has changed quite a bit, right? And so we've gone, come a long way from just utilizing paper forms and tracking the information through, sometimes Excel sheets. We really had to figure out, how do we modernize our system so that we can use data in real time to make progress? And that's really been the goal for the department. So what does performance management actually mean? And it's really just looking at performance standards. What are our goals? What are our goals as a state? What are our goals as individual programs? What are our goals as municipalities or counties? What do we want to see? And then what metrics are we going to use to track that? And then reporting that progress, and then creating quality improvement processes to really help make sure that we're meeting those goals. So here at DOH, and one of the things that I've now taken on and trying to help the department do is form a performance management unit with a grants sub-unit, and looking to foster better practices across different programmatic activities, including oral health. Really figuring out, how do we create these goals and then enhance the performance through tracking and dashboards, so that both internally we understand what's happening, and then externally we can work with our partners to say, hey, we want to make sure that we're moving in the right direction. So just to kind of go a little bit more into performance management, it's really making sure all of leadership, so that's both internally and externally, understand what these goals are, and that we're all moving to the, in the right direction. So it's identifying, as I said, those standards and setting those goals, communicating those expectations. So, in oral world, really working with all of our stakeholders, both on federally qualified health centers and, associations and hospitals and private practices, and really saying, hey, as a state, this is where we want to go. How do we make sure we get there? And then, as I said, defining those measures, really using that data in real time, which is really why that data modernization is such an important thing. How do we see what's happening? That was something that really was helpful in COVID. We saw every week, every day, this is what's going on. This is where the numbers are. This is where we need to allocate resources. This is where we need, this is a population that we really need to focus on. We were able to, in real time, understand the needs and then pivot as needed. And so that is really important. And we want to see how we can do that across different health outcomes. And then, as I said, quality improvement, really making sure that we have processes in place, and we're utilizing that data to then shift and change and say, hey, this is a best practice. Maybe that wasn't working in this area. So that real-time ability to shift. Sorry, next slide. And so, looking at how this, works in real life, we, were able to publish our New Jersey Oral Health Plan that really was spanning 2023 to 2028. And one of those objectives is really to outreach to residents through patient education, right? And so oral health literacy, focusing on vulnerable populations, which populations have, high levels of dental caries, those types of things, collaborating with schools, tracking, performance via those data collection internal dashboards, and then evaluating the outreach success. These are the things that we have said, hey, this is what we want to do, but it really requires us internally having metrics, and then working with our stakeholders to ensure that those metrics, to really ensure that those metrics are being implemented, that everybody has the resources to do this, and that as a community, we understand the goal that we're trying to get to. And so this is in one way what, performance management would look like as a state is working both internally and externally with our stakeholders to get to this goal and these objectives. And so then, as I mentioned, kind of going back into quality improvement, and then also having that feedback with our stakeholders. What are the, what's working, what's not? Having that open communication, I think both internally and externally, is incredibly important to make sure that we're moving forward as a state. And that often is, what we consider the PDSA. And everybody always sees this, especially when you're applying for grants, right? The plan, do, study, and act. What is our plan? How are we implementing it? Are we studying and making sure that we're actually tracking that? And then are we acting? And I think both, internally within DOH, and then the ways in which we work with our stakeholders, really want to make sure that we have these processes in place on both levels. And so, our stakeholders can also hold us accountable and say, hey, what is happening in this space? What are we doing? What is the data that we're seeing? And then how are we going to move forward? This is what our thoughts are. What are yours? That's that collaborative manner that really, I think, helps us move, into 2030. All right, I kind of ran through that pretty quickly. Yeah, this was just really trying to give everyone an overview of what our goals are as a department, and trying to make sure that we, COVID, I think, was a not wonderful, but it was a way for us to understand that there were gaps in the system. And we really want to make sure that we're addressing some of those gaps and that we're saying, hey, as both in an organization and the stakeholders that we're working with, because we're not doing this on our own, we're really just a body to say, hey, this is what's going on. How do we move there? That we really need to make sure that we have all those systems in places and the resources in places. And so our goal is really to work with our lovely, stakeholders like Zufall and our hospitals and our dental associations and all of the organizations that, are in Jersey to ensure that we are making the progress that we want to make and seeing those outcomes that we want to see. So this is my contact information. If anybody has any questions, please let me know. Thank you.
Thank you so much, Dr. Taiwo. Your presentation really highlighted the fact that New Jersey is in great hands. And I love that you are pushing the agenda of healthcare, quality healthcare forward. And I'm so happy we got a chance to highlight the work that you and your department has been doing to show that Zufall is contributing to this. And we are very grateful to have you with us. Thank you so much.
We're grateful for the partnership.
So we'll be moving on to our next speaker. Our next speaker for this plenary is Dr. Luis Padilla. Dr. Padilla is a licensed family physician and chief medical officer with the National Association of Community Health Centers. Previously, Dr. Padilla served for nearly a decade with the Health Resources and Services Administration, HRSA, as the Associate Administrator for the Bureau of Health Workforce and the Director of the National Health Service Corps. He previously held leadership roles with Unity Healthcare, the largest community health center system in Washington, D.C., and is a past member of the National Advisory Council of the National Health Service Corps. Dr. Padilla earned his medical degree from Wake Forest School of Medicine and completed his family medicine residency at Brown University. He holds a Bachelor of Arts in Philosophy and a Bachelor of Science in Biology from the University of California at Irvine. Dr. Padilla, welcome, and we're excited to hear from you. You have the stage.
Thank you, Dr. Duncan. Thank you for that very kind introduction. Probably more than what I needed, but a pleasure to be here with you today. And it's a pleasure to be here with you and an honor to represent the National Association of Community Health Centers and share how health centers are providing critical oral health services, training future health oral providers, and integrating oral health and other care services within and outside their health centers. As many of you know, today, health centers are caring for more than 32.5 million Americans in rural, frontier, through its nearly 1,500 health center network, encompassing nearly 16,000 sites across the country. And for nearly 60 years, health centers have been doing this by addressing health equity and health disparity as the center of their mission. And oral health is certainly a fundamental service that health centers provide and are often a means of entry into more comprehensive services at health centers and an entry point to medical and behavioral care services. In 2023 alone, health centers provided over 12.5 million oral health care visits, an average of over 9,100 visits per health center that year alone. But as we look at where we are right now in simple terms, the supply of providers, particularly oral health providers, but many others, is not meeting the demands. Those 12.5 million visits are a big accomplishment in 2023, but there's a great need for more services, as you well know. Across the health center movement right now, there are over 5,400 FTEs of dentists, over 2,800 FTEs of dental hygienists, and other dental personnel that are over 12,000 personnel providing oral health services across the country. But yet, as HRSA has shown through its health profession shortage designation program, there are over 6,800 oral health profession shortage areas across the country. So there certainly is a lot of work to be done in terms of developing the workforce to meet this very pressing demand for oral health services across the country. So as we look at NAC, at our vision for what health centers need to do to be at the center of driving their workforce development, we understand that health centers, in order to continue to deliver the premier services that they do, whether it's in medical, behavioral, and certainly in oral health, we need to also become the premier teaching environment for current and future health workforce providers. And certainly that is the case for oral health. And so our goal in the interim right now is to implement a health center driven workforce development framework that builds off a lot of the evidence-based training models that already exist within health centers and continues to advance innovation. So as we look at health workforce and having health centers drive this workforce development, we look at it through the lens of what we call the SEP model. This is a framework that was developed by NIH, and it helps us identify some of the important areas here in workforce development. So whether it's identifying gaps in current training models, demonstrating the successes of providing education and training within community health centers, and show that they improve access to care, that they improve the quality of services that are being provided in health centers, and that they increase recruitment and retention of talented, culturally competent providers across all of their disciplines and workforce streams. We understand that the pressing needs of the demand side of the equation, as I presented earlier, are going to require us to take a look at other solutions. The most pressing how do we incorporate value-based care in the delivery of medical, behavioral, and certainly oral health services? And how do we start to position ourselves from a policy position, from a policy standpoint, to advocate for changes in funding that will help drive future workforce into community-based organizations like FQHCs and others? We know that there are a lot of challenges in this approach, not the least of which is cost and access to education and training, but also regulations at the state level and at the federal level. And certainly, as is the case in oral health and certainly in primary care, reimbursement inconsistencies are a big component of why we're encountering challenges in developing a workforce to meet our needs across the country. To that end, in October of 2024, NAC released a guide, State Policies and Strategies to Strengthen and Expand the Dental Workforce in Health Centers. This report was authored by Dr. Hannah Maxley at Indiana University and Courtney Medlock in partnership with NAC and with funding from CareQuest Institute for Oral Health. This guide provides significant support for health centers and advocates to look at their state level policies, to strengthen them, to expand community-based health center-based training, to increase those pathways and connect students to meaningful careers. Health centers are uniquely positioned to partner with states by serving as training centers for aspiring and new licensed dental professionals. On the secure side, state policies and programs can enable workforce incentives that help health centers recruit and retain mission-oriented professionals. Programs like scholarships, loan repayments, et cetera, to help support the recruitment and retention of oral health professionals into health centers. And to maximize state policies that can encourage dental workforce innovation and authorize dental professions to practice at the fullest extent of their training to continue to provide quality services, again, to those more than 32.5 million Americans across the country. We believe that health centers should be aware of state policies and strategies that exist and identify related opportunities for funding. Health centers can advocate for similar policies within their state. And in this guide, you'll find a description of state policies and strategies that can support the growth of programs to train, secure, and maximize opportunities for the dental workforce in health centers, including practical recommendations for health centers to take action. Provided in this guide is 11, quote, shining stars, case examples, if you will, presented at the guide that illustrate how health centers across the nation have used a variety of state policies and strategies featured in this guide to improve access to high quality dental care for underserved patients. So we're not operating in a vacuum. And as I mentioned, there are many training models that are already underway across the country within health centers, whether it's in Michigan, that's created federally registered apprenticeships for health center dental assistants, or in Family Health of Mansfield, that is providing a state-supported scholarship for dental assistance training in Wisconsin, that adopted a state funding model to provide technical assistance for the development of dental residencies. At HealthLink, workforce development funding to support employer-based training. And at Penobscot Community Health Center, leveraging state regulatory policies to support the training of dental assistants within health centers. And certainly in Ohio, the state funding was utilized to support dental and other student clinical rotations at health centers. So these models represent a broad array of opportunities that health center and academic partners at the state level can lever to support the future workforce within health centers. And I just want to give a special shout out to my colleague, Meg Mader, director of NAC's Million Heart Program, who's presenting later on with Amy Allwood from Michigan PCA on the importance of integrating care teams in the management of hypertension. So thank you, Meg, for that. The National Service Corps is proud to partner with the Henry Schein Cares Foundation and their partners on this multi-year project to support patient adoption of a preventive integrative care model to improve overall health outcomes. We're delighted that this year, many of these health centers listed here are training their teams to take accurate blood pressure in the dental clinic to screen for hypertension. And we're excited that in year 2, we're going to be looking at health centers that are integrating oral health and type 2 diabetes care models. Such an important facet of managing chronic disease. As I said, oftentimes diabetic patients or those suffering from chronic disease see oral health visits as an early entry into health centers and providing more comprehensive care. And in year 3, we're looking forward to looking at the integration of oral health and maternal health care models and those health centers that are developing those models, again, to integrate and to link oral health services with the care of maternal health patients within their communities. So I want to end by going back to where I started, and that is this what may seem like a simple equation of supply and demand, but certainly is imbalanced right now. And as we continue to support health centers to enhance and expand their oral health services, we are pleased that we have dedicated partners, and many of you here in the audience, dedicated partners to help us better balance this equation and continue to provide quality, integrated oral health services within our health centers. And so I thank you for the opportunity to present to you. I hope you enjoy the rest of the symposium. And thank you very much.
Thank you so much, Dr. Padilla. We do have some questions and we will ask them at the end of the session. So we would invite you to come back up so we could ask you the questions that we have for you in the Q&A box.
Sure. Thank you.
Thank you. So our final speaker for this morning's plenary is Allison Neale. Allison Neale has 25 years of experience in global health, corporate social responsibility, and human rights. As the Henry Schein's Vice President of Public Policy, Neale leads the company's public policy and global health engagement by partnering with government, industry groups, non-governmental, and intergovernmental organizations. Neale also leads the Henry Schein Cares Foundation, which advocates and supports efforts to advance health equity and empower healthcare professionals to promote a healthier tomorrow. Neale received her master's in public policy degree from Harvard University's Kennedy School, where she was awarded the Pforzheimer Merit Fellowship and received her bachelor's degree magna cum laude from Tufts University. Welcome and good morning, Allison. You have the floor.
Hello, Dr. Duncan, and thank you so much for having me here today. Can you hear me okay?
Yes, we can.
Perfect. Well, I am so delighted to be with you all today for this very important conversation and our terrific partners, Zufall and the National Association for Community Health Centers, the Department of Health, and so many others. Just really so pleased to be with you here today. So thank you for having me. Can we advance to the next slide, please? Great. For those of you who aren't familiar with our company, Henry Schein, we are a leading provider of healthcare products, services, and solutions to office-based physicians and dentists. So essentially, If care is taking place outside of the four walls of the hospital, those are the health professionals that we serve at Henry Schein. And our business extends, you can see here, to 33 countries. And we have a team of more than 25,000 team members across the world. So given our position as a company focused on preventative healthcare and the nexus between oral health and overall health, clearly today's program is very close to our heart. And you can see here just a couple of quick facts about the company, but perhaps most important is that bottom row, where we really underscore our commitment to doing well by doing good, which has been really embedded in the foundation of our company since 1932, when it was founded by Henry and Esther Schein as a mom and pop pharmacy in Queens, which is actually where I live right now. But you can see that this commitment is really deep, and it's really a part of who we are as a company and all that we look to do. Can we advance to the next slide, please? So for the past 4 decades, we've been focused on creating shared value for all of our stakeholders, and we utilize a model that we call the mosaic of success. You can see here what we think of as our mosaic of success. It includes our customers, which again are physicians and dentists around the world. It includes our manufacturing partners or suppliers. We partner with more than 4,000 supplier partners around the world to help us deliver all of the products and services and solutions that physicians and dentists need. We, of course, have a responsibility to our shareholders as a public company. And we also include as our key stakeholder society. And we really view society as a core part of this mosaic that makes up our success. And in the center of that is our team of 25,000 team members who work to create opportunities to engage all of these other stakeholders in our collective mission to make the world healthier together. So if we can just advance to the next slide, please. And we've found that the most impactful way for us to do that is through a model of public-private partnership. And I've shared here the way that we think about what public-private partnerships look like. So we believe that each stakeholder in society has a really critical role to play. Each brings unique expertise and capabilities and competencies. And the only way that we can really solve complex healthcare issues is if we're all working together collaboratively in the long term to work on these issues. So you can see here, industry, companies like Henry Schein can bring donated product, our expertise, our relationships, our resources, but we can't do it without the health professionals who need to deliver the care and provide their expertise and skills, and partners like Zufall, for example. And we can't do the work without partnership from nonprofit organizations who really bring that local community expertise, and of course governments who provide us with that broad mandate to action. And so you can see here what we think about as sort of the flywheel that makes this whole effort work. Can we advance to the next slide, please? Great, thank you. The Henry Schein Cares Foundation, which I lead, is part of that circle. And so we aim to improve access to healthcare and strengthen health equity, focus on 4 key areas of focus. So first is advancing access to care. So that's really helping to partner with others to provide care to at-risk and vulnerable populations, those who are underserved or underrepresented. Second is promoting a holistic model of healthcare, which really today's summit is all about, right? It's about integrating oral health and mental health within the ambit of primary care, because we believe that really solid healthcare requires a holistic view. And our third pillar is building capacity to empower healthcare professionals. So within that scope of work, we focus on supporting a diverse healthcare workforce, I believe Dr. Padilla spoke a little bit about workforce challenges within healthcare. That's the pillar within which we focus on really building capacity and supporting the needs of healthcare professionals. And lastly, that green pillar, catalyzing innovative models for emergency preparedness and response. We have for many decades been very focused on responding to natural disasters, disease outbreaks, humanitarian crises, and in particular, helping healthcare professionals help health happen in that context. And so when we respond, we're supporting the healthcare professionals who are on the ground doing the work, as well as when healthcare professionals have their practices or clinics who are impacted by natural disasters. We also work to help rebuild. Next slide, please. Great. And I saw in Dr. Padilla's slides that he also shared a bit about our Prevention is Power program. We were really excited, the Henry Schein Cares Foundation, to develop this partnership over the past year. Prevention is Power. We are so thrilled to have had the American Dental Association, the American Medical Association, the National Medical Association release the pressure. The Gold Foundation, which of course is the organization that does white coat ceremonies in all medical schools and nursing schools, and focuses on humanism in healthcare. CareQuest, and of course NAC, the National Association of Community Health Centers, and we also work with CUNY School of Public Health. But through this effort, we are really looking to raise awareness among patients of the critical connection between NCDs and oral health. You can see here our three key areas of focus: heart health and oral health, diabetes and oral health, and maternal health and oral health. And we'll talk more about that later this afternoon in the session. Next slide, please. Wanted to just share a couple of examples of the kinds of public-private partnerships that I was describing earlier to really bring the concept to life. In our work to increase overall access to care, we're particularly focused on catalyzing partnerships that address glaring gaps in access for vulnerable and underserved communities. And so I'm going to give you a couple of examples now, one for older populations, one for individuals with disabilities, and one for underserved children and their caregivers. So this program is near and dear to my heart. I founded this program in 2015. And the White House sort of raised our awareness of the needs of Holocaust survivors in this country. The Holocaust survivors living in this country, on average, live in higher states of poverty than others in their age group. I think it's 33% of Holocaust survivors live in low-income situations, as opposed to about 9% of the population of older adults in the United States. We also understood that they have faced significant oral health challenges. They didn't receive dental care as children and young people, and that combination of not getting care throughout their lifetime, we really, many are living in quite a bit of pain and not able to eat properly or speak comfortably. And so we partnered with a dental fraternity, Alpha Omega, and incredibly had 500 dentists and oral health practitioners volunteer to work with us. We have thus far provided free dental care to 2,500 Holocaust survivors across the country. The value of care is $5 million thus far. We are partnered with 5 dental schools to deliver this work, also with the engagement of dental students, with the understanding that this is a great way to help students understand their role in society and their opportunity to really give back to communities. And we're in 23 cities. In my next session, I can share a bit more about the program, but it's been really incredible to hear the stories of the survivors and the impact that this care has had on their life, and also on the providers and the special opportunity it provides for them to give back. Next slide, please. Great, thank you. Another key area of focus for us is supporting the needs of individuals with disabilities. Although 1 in 4 Americans live with a disability, these individuals often face daunting hurdles in accessing healthcare, and especially oral healthcare. And so we've worked for a very long time in partnerships with professional associations, patient advocacy groups, dental and medical schools, policymakers, and other healthcare professionals in a variety of ways. First, we work to raise awareness of the importance for oral health with people with disabilities and their challenges in seeking access to care. We co-founded an organization called Project Accessible Oral Health that catalyzes healthcare professionals and others to advance health equity for this population. We also have a great partnership with Special Olympics International since 2017 that advances diversity and inclusion training to support their Healthy Athletes program, which provides free healthcare screenings and education for the athletes. And it also provides the opportunity to help healthcare professionals train to learn how to treat this population. We also think that education is critical. And so we've partnered with the National Council on Disabilities to educate medical and dental professionals in disability care. The results have been really incredible, impacting the lives of tens of thousands of patients. We welcome others to join us. We have information on our website about providing care to individuals with disabilities, but really believe that this is a critical area that all need to focus on. Next slide, please. So one other area which just wanted to highlight is our work with children. We are one of the co-founders and champions of the ADA Foundation's Give Kids a Smile program for the past 2 decades. Over the course of our 20 years, we've helped 7 million children across the United States access free oral care. And we have approximately 1,500 events every year. And it's a great opportunity for clinicians to participate in this effort, which takes place the first Tuesday of every February to provide care for this population in need. But it's another great example of sort of what this public-private partnership concept looks like. Can we advance to the next slide, please? We also work to advocate for access to care globally. And one example of this work is our partnership within the World Economic Forum. We've been working really for the past 2 decades to elevate the importance of oral health within the dialogue at the World Economic Forum. And we recently co-founded this oral health group together with Colgate-Palmolive and the American Dental Association. The focus of our work together is really to move the needle with governments around the world to invest in oral health care for their populations and to understand the opportunity to elevate health outcomes for their patients and to lower healthcare costs by investing in healthcare. We published a report this past year, the economic rationale for a global commitment to invest in oral health. You can find that just by Googling oral health in the World Economic Forum. It'll come right up. And we also have several other pieces that we've worked on. And now we're in the process of working to advocate with ministers of health and ministers of finance to deliver on that goal. Okay. Next slide. And I know I'm guessing, Dr. Duncan, am I running out of time? Should I speed up? Yes. Okay.
You have a couple more seconds.
Perfect. So let's advance just to the end. We can skip this slide as well. So just go back one. Yes, thank you. In conclusion, I just wanted to, end this discussion where we began. We really can't make progress in advancing any of our shared goals to provide access to care for all if we don't collaborate and partner with one another. So we're so thrilled to be here with Zufall and with all of you to advance this concept of working together to create a healthier world. So thank you very much. Together, I know we can move mountains.
Thank you so much, Allison. and Dr. Padilla and Dr. Taiwo. We do have a couple of questions, so I really wanted to get a chance for the audience to engage with us. So the first question is for Dr. Taiwo, because it is about New Jersey specifically. Carolina Zavaleta asks, what are the policies that are in effect in New Jersey that can help maximize revenue for health care centers like ours? So I'm assuming she works for a healthcare center, probably Zufall.
Awesome. Yeah, so there's different, as you know, I'm really happy that Dr. Padilla had mentioned some of the HRSA project or HRSA programs, especially like the loan redemption programs, and getting more workforce in there into our offices. So that is definitely a thing. Regarding so are we asking more like Medicaid reimbursements or
It
kind of
seems to be a general question, so you could tackle it from whichever angle you think will be meaningful.
there are definitely lots of grant opportunities that the Department of Health has that are really trying to ensure that, especially when folks are working with underserved populations, that they have the capacity to do that. And so I would definitely look at some of our Department of Health grants to see how to maximize resources. And then there's also just like, you know, various partnerships that we've been looking at and trying to see how do we maximize those resources. There's some federal funding that we are trying to tap into to also expand resources across the state. And so, yeah, I think there's outside of the grants, I mean, because I'm working for the Department of Health, I can't really talk regarding Medicaid reimbursements, but there are definitely quite a few Department of Health grants that I think would help to maximize resources and help with revenue within health organizations.
Thank you so much, Dr. Taiwo. Dr. Padilla, is there already or are there plans for a central hub of training models that health centers are successfully using?
Yeah, thank you. And that's a great question because I think that's one of the challenges. We have so many models and trainings out there, many of which are doing great work and enhancing the workforce, but we don't have a centralized area right now. Certainly my time at HRSA, we tried to address that and catalog and house a lot of that. Some of the activities in this space include our primary care association colleagues across the country are forming what's called a PCA hub to do just that, to collate and disseminate a lot of these models. So certainly NAC wants to support that effort, but we're also beginning the process of identifying these models across the country and figuring out where to store it and how best to disseminate that information. So we'd like to work with partners on this and our PCA and health center partners to get a better handle on what's happening across the country and what are the best practices in terms of training models for oral health providers.
Thank you so much, Dr. Padilla. And speaking of partnerships, Allison, I guess this question is for you. How do you connect with stakeholders to engage them in partnerships? All of the thread of everything that all of you spoke about was partnerships. So
Thank you, Dr. Duncan. Yeah, I mean, I think what's critical in trying to create impactful and sustainable partnerships are finding those issues that really resonate with each of your stakeholders and finding meaningful ways for each partner to participate. Everyone has to have a stake in the game and a critical role. And I think it's also, you know, I think we're lucky as a healthcare company that naturally we're given sort of a purpose-driven mission, right, to provide clinicians with the tools they need to provide the best care they can for their patients. And so I think when we can find those kinds of programs and initiatives that really resonate with clinicians, that resonate with our supplier partners, and with community partners and NGOs, and we can bring everyone to the table and give everyone their own really strategic role that fits what they want to do and that fits their best core capabilities. That's kind of when the magic happens and we see the most impactful results.
thank you so much. We had a comment about really trying to engage people straight out of high school into dental school like other countries had to shorten that gap and to get the workforce out much quicker. we've seen the models work in other countries. So someone was just suggesting, why don't we do that? And then the last question is for Dr. Taiwo, or anybody who wants to be put on the spot. Given the shortage of dental providers in FQHCs, is there a possibility that New Jersey or more states will work towards establishing licensure for dental therapists?
That is actually really interesting. And so there definitely have been conversations, especially with, during the pandemic, of how do we expand access? How do we expand the capabilities of providers across the state when we realized that we needed everybody, all hands on deck at the end of the day. So I do think that is something that we could, really discuss and really try to push forward and trying to figure out how do we expand access among dental hygienists, how do we expand access among dental therapists, and just making sure that everyone on the ground has the capacity to do their work without, not being able to access those licenses. So I do think that is a conversation that we would love to have going forward.
Thank you
And-
so much. Oh, go ahead. Sorry.
Sorry, Dr. Duncan, I was going to just say I can take that first question. What I shared today was just a couple of small examples of programs, but we actually have a program that addresses exactly that issue. It's called the SMILE Healthcare Pathways Program. And we engage young high school students from around the country, from diverse backgrounds for a summer camp. And it's held at historically Black colleges and universities. And we provide them mentorship with dentists and hygienists and other practitioners, and they get to practice some procedures on models, and they get to learn kind of what it is to join the oral health professions, and the concept really is to just provide that spark and interest in joining the profession later in their career.
Thank you so much. So we are at the end of this morning's plenary. Those of you interested in our CE, please see the link to the survey in the chat. Remember, if you are looking for public health or chest, that's for the whole day, and that'll be at the end of the day. So we want to say a big thank you to Dr. Daywalker for a keynote address, Dr. Taiwo, Dr. Padilla, Allison, for really highlighting the work that's already being done, and to really encourage us to keep working towards it, because we're all in this fight together. So please remember to take the survey, guys, to get CE credit. You have until the 24th of this month. And now you will now be routed back to the lobby, and please take advantage of the expo session in between you running for coffee. All right. See you guys again soon. Bye.